All right, I think we've got pretty good numbers here, so let's get started. Good afternoon, everyone. I'm Sam Wood, one of the internal medicine chief residents. Welcome to virtual grand rounds. Thank you all for joining us. So please join us next week in person for the 67th annual Pinkoffs lecture. It's going to be presented by Dr. Henry Mazer, and it's going to be about the HIV pandemic. Should be a really great talk, and again, it's going to be in person, so please make your way down to the Shock Trauma Auditorium. We're really excited to have a good big crowd there next week. Today's Grand Rounds is our quarterly session from ICTR, the Institute for Clinical and Translational Research. It's titled Utilization and Effectiveness of Using a Patient Portal for Health Research Recruitment, and is being presented by Professor Carrie Dykes. Dr. Dykes is joining us from the University of Rochester to tell us about a new service there, MyChart for Recruitment. She holds a PhD in microbiology and immunology from the University of Rochester, MS from the Simon School of Business and Medical Management, and a BS in biochemistry from Nazareth College. She's the Director of Research Services at the University of Rochester Clinical and Translational Science Institute, where she conducts research in recruitment and retention. So please welcome Dr. Dykes.
Thank you very much. That was a very nice introduction, and I'm really happy to be here to talk about our new service. So let me share my screen. There we go. So yes, I'm going to talk about the utilization and effectiveness of a patient portal for health research recruitment. First, I have there we go. Just want to say that I have no conflicts of interest to resolve for this talk. So I think we can all agree that recruitment of participants into clinical trials is really hard. And, 50% of trials fail to recruit and retain the appropriate number of participants for their primary endpoint to be met so they can determine whether the clinical trial worked or not. And we think that's because most researchers don't think of recruitment as a science like they do the rest of their science. And so plans for recruitment should be informed by the literature and by previous experience with other research studies that researchers have done themselves. And most importantly, data should be collected and tracked in real time about how many people are contacted and move through the recruitment funnel, so that adjustments can be made in recruitment plans if things are not going according to plan. And the CTSA program has long recognized recruitment as a translational science barrier and have funded the Recruitment Innovation Center at Vanderbilt University Medical Center, which is part of the Trial Innovation Network. And I've included a QR code here for the RICS Community of Practice, of which I manage. So if you are interested in recruitment and want to talk with other people at all different institutions about best practices around recruitment and retention, you can scan this QR code and sign up to be part of the group. So the use of the electronic health record for recruitment has been going on for a decade in different ways. And we know from research that patients really do support direct contact about research opportunities by researchers. They like to know that their clinician supports their participation in research, but really want to have direct access to the information. And so the EHR is one tool that can be used to do this. And it's been utilized by different institutions in a variety of ways. The first is point of care notices. So these are alerts that the clinician would get in the EHR when they meet with a patient, and it would tell them that this patient may be eligible for this study. And the clinician would say, we have a study opportunity. Would you like someone to come in and explain more? And so that's one way that you can get information to patients. Other institutions use the EHR for their research registries, institutional registries. And so at clinic registration, they ask patients if they would like to join a registry. And then, of course, patient portals and messages through the patient portal is the most common way that the EHR is used for recruitment. And at our institution, our patient portal is called MyChart. And there's over a dozen institutions that are using MyChart to send messages. And in fact, just a couple days ago, Johns Hopkins University gave a webinar about how they do it. And this was a TIN webinar through the Trial Innovation Network. And I included the link here so that you could also see how they're doing it. Because what we've learned about the CTSA program is every institution is different, and we all do things a little bit differently. So this is our recruitment unit at the University of Rochester. And I wanted to give a little bit of context about what we do as a recruitment team for all of our services, so you can kind of see how MyChart fits into the big picture. So Dr. Ann Dozier, who's the chair of public health sciences, is our leader. And we have Cody Gardner, Karen Vitale, David Pinto, Pavitra Pinjala, and Deepa Premnath, who are all part of the team. So we've built a very multidisciplinary team that includes people who are experts in recruitment, experts in population health, informatics, data analytics, as well as education. And so this has helped us to create a very well-rounded group of services. The recruitment unit fits within the research services branch in our CTSI structure, of which I am the operational director for. And the mission of the service of the branch is to provide efficient and high quality research services to our faculty, staff, trainees, UR medicine patients, and community members. And you can see that in addition to recruitment and retention, we have the Office of Clinical Research, we have regulatory support, funding programs, and a number of other resources. And this branch fits within our larger CTSI structure, of which there are 5 branches. And this is essentially how we operate. It's a matrix organization. We're very cross-collaborative. But we have a population health branch, informatics, research education and career development, and translational science. And then one step up from that, our CTSI fits within our research hierarchy under the Office of the Senior Associate Dean for Clinical Research. And in fact, Dr. Martin Zand, our dean, is also co-director of our CTSI. And what that has allowed us to do is have a very effective way of implementing services that can affect other offices, both within research here on the left, as well as clinical supports on the right. And I'll talk more about this structure later when I talk about implementation. But our services are basically 4 different things. We do consultations, we have education, we do surveys, and we have a number of tools and resources. Our consultations are, one-on-one consultations with the researcher to really, hammer out effective ways to recruit the population that they're going to recruit. And we often write recruitment plans for grant applications or protocols, things like that. Dr. Dozier and I also teach a recruitment and retention course. It's a 3-credited graduate level course that's offered through Public Health Sciences. We do 2 surveys. I'll talk more about those in a minute. One is a survey of research subjects, and one is a survey of our community about research. And then we have these various tools and resources that I'll talk in more detail about, with the exception of the Greater Rochester Practice-Based Research Network. This is a network of primary care practices across Monroe County and around our catchment area, essentially, in Western New York, and includes both our health practices as well as the Rochester Regional Health practices. And they're basically primary care clinics that are interested in research, particularly in the area of primary care. And then, of course, MyChart for recruitment, which is what we're going to talk more about today. So our CTSI and our recruitment unit manages our institution's public-facing website about research. It's called UR Health Research. And it basically has 3 ways that the community can interact with us. There's a place where they can learn more and read more about what health research is. They can search for studies that are currently enrolling, and we have about 615 studies in there. And they can volunteer to be in a registry to learn about research studies that come up in the future. I will say, when people visit this site, the number one thing they do is search for studies. So we try to make sure that that is up to date and accurate. The website has a companion Facebook page that we actually use to run Facebook and Instagram ads through. So we, as an institution, all advertising on social media for Facebook and Instagram go through the UR Health Research account. It makes it more clear to the community. It validates for the community that this is an authentic research opportunity, and it brings more traffic to our website. In the CTSI, we also provide Facebook services. So we will help investigators design Facebook ads, figure out what audience they need to use. We will load up and launch the Facebook ads for them and send them data on the results afterwards. So we've done 91 campaigns for 71 projects so far in the past 4 years. And we're finally starting to get investigators to think about recruitment as a science, as I mentioned before. And we're getting them to say, you know, you should write a manuscript about your success with Facebook recruitment, because everybody wants to know how to recruit with Facebook. And these are just some examples of research projects that have successfully recruited for their studies and will be or have published manuscripts about it. I mentioned 2 registries. Researchmatch.org is one of them, and then what we call our local registry, our CTSI research registry. Researchmatch.com is a national registry that was created by Vanderbilt University Medical Center. It works like Match.com, where investigators will put in criteria about what participants they're looking for, and then participants will put in their information like demographics and diseases and medications, and then the system matches the two. And it will send a message to the volunteer saying, you know, we have this study, are you interested or not? And if they are, then the research team will get their contact information and they can follow up with them. Since it's a national registry, it works really well for survey-based research or remote studies, because you have a pool of over 157,000 people you can recruit from over 230 institutions across the country. However, it does have a geographic component to it. So if you do actually need to have a participant come into your location to do a visit, you can narrow the search to your geographic location. Our local registry has over 15,000 participants in it, 2/3 of which have an email. So we do send weekly emails of recruiting studies, usually studies for which we've recently consulted, where they're struggling and they've needed some assistance. We will get the word out to our registrants through email. And we've had a nice growth of registration over the years. And this is due primarily to the fact that we use our emergency department to recruit. So the emergency medicine department has research associates that basically run around the ED and screen people for studies. And it can be, they screen for all kinds of studies, not just emergency medicine. So we, ask them, can you enroll people in our registries? And so when a patient is in the ED and they're bored because they're just sitting there doing nothing, a research associate will ask them, would you be interested in signing up for a research registry for, learning about studies in the future? And what's nice about this is our emergency medicine population is more diverse than our overall UR medicine population of patients. And so we have a nice diverse population of Black and Hispanic registrants, which is similar to our overall county census data. I mentioned a couple surveys that we do. One is called Empowering the Participant Voice. This is actually an NCATS funded collaborative grant that was funded to Rockefeller, but includes us and Vanderbilt, Johns Hopkins, Wake Forest, and Duke. And basically, we've implemented a plan for how to do survey-based research on research subjects at an enterprise level. And this is using a validated survey that was previously published called the Research Participant Perception Survey. And it collects information about satisfaction with the research experience, questions about informed consent, coercion, how to could they reach the research team when they needed to, as well as questions around respect, courtesy, and value. And I've color coded these because what we've learned from doing this survey is we have some areas here in green, which we really do well in. We get high scores for, and, don't really, have a lot of room for improvement, really. However, there are some areas such as overall satisfaction and informed consent, where we could definitely make some improvements. Our scores aren't horrible, but they're, definitely could have some improvement there. And so we're working now to figure out what interventions can we do at an enterprise level to hopefully bring up our scores for all research subjects. If any institutions are interested in implementing empowering the participant voice, please let me know. If you're interested in doing that, we can get you connected with Rockefeller. And then the other survey we do is our community. So these are not research subjects. These are not patients. We go out into the community and collect data on whether our community thinks research is important and what kinds of research they're willing to do. We do it every other year. And, in general, the response is positive. 80% of participants think health research is important and we should be doing it. They're less willing to do things like get a drug or a device or do a vaccine or get a shot or whatever, which is not surprising. But one question we do include every year is asking their opinion on whether they think Black and Hispanic or Latino people think that they're more likely to be asked to participate in riskier studies. So white people don't think Black and Latino people are asked to participate in riskier studies, but Black and Hispanic people do. And this is despite the fact that Black and Hispanic people have already in previous surveys said that they trust the University of Rochester as an institution, but do think they're likely to participate in riskier studies. And so we have some work on trust to do with regards to that. We also use it just to look at different subpopulations and how they compare to the overall results, like what do rural communities think and what do specialty patients think, like patients in our complex care clinic. So this is an overview of, what we offer as a whole to our institution for recruitment services. We have our consultations, we do education, we have surveys to get evaluation feedback back to us, and then we have a number of tools. So then we decided, how about my chart for recruitment? And really why my chart for recruitment? So the first thing is, we went and looked at what other institutions were doing. And I talked on an earlier slide there about how some people use point of care alerts. That was a no-go with our clinicians. They wanted no more alerts at all out of the EMR. They just didn't want it. So we said, okay. We already have a really good, robust process for our registry. So we didn't really feel like we needed to upset the apple cart there by using the EMR as a way to do registration. But what we do have at our institution is a no cold calling policy. So the U of R is what's called an opt-in institution. So if a patient wants to participate in research, they have to opt in to be contacted. And so the only way that a patient can be contacted directly is if you first get permission from their clinician to contact them. And so the problem is researchers who don't have access to patients or don't have access to other clinicians' patients could not contact patients directly. And this was providing a huge barrier where basically the institution said you need to contact the clinician, get their permission to contact the patient, and the clinicians, rightfully so, just don't have time to give permission and respond to all these queries. So because of this no cold calling policy, we thought my chart would be a good solution for overcoming this recruitment barrier. So this is the timeline for implementation of our project. We started back in Q2 of 2020 when the clinical side of operations told us they were going to be doing an Epic upgrade in 6 months, and there's going to be this research studies page in it, and what do we want to do with it? And we were thinking at the time, oh, we want to do my chart for recruitment. So this may be a great opportunity to do that. And so we upgraded Epic in October of 2020, and we formed a working group. I'll go back to our chart here. We had members of the recruitment unit from the CTSI. We had the vice president for human subjects protection was also part of the working group. We had information technology, because that's where Epic is and sits. And then we had members from privacy and security, all working together to figure out a plan of how we were going to do this. So we did the Epic upgrade, and we developed patient communication about the research studies page and this new opportunity for them to get contacted about research. And we did that for 6 months. Then we launched a 5-month pilot where we had about 7 studies that we started actually sending messages for. We looked at what were our patients saying, if anything, what were clinicians saying, if anything, and how well was our process working. Made some adjustments, and then opened the service to everyone at the beginning of 2022. And what I'm going to present today are results that were collected a year later on the messages that were sent. So patient communication. We did everything we possibly could. We used every possible piece of real estate in online and in eRecord to let patients know that research was now in MyChart, and they had this research studies page, and how could they learn more? And more importantly, how could they opt out? Because we are an opt-in institution, this was a big change for us. When we implemented MyChart, we implemented it as an opt-out thing. So all patients are in the bucket to be contacted, and they have to opt out if they don't want MyChart messages about research. And so because this was new for us, the institution wanted to make sure they had lots of opportunities to see it and go in and opt out. So we put it, when they first register for their account, there's a research statement about it and how to opt out. In our online MyChart terms and conditions, there's a research section. When you log into MyChart, one of the banner headlines talked about this, which we branded as Research Connections for our patients. Also at the bottom of the login screen, there's a thing about Research Connections. You can see the theme here. And this was for about 3 or 4 months when we first launched it. Whenever a patient got any message from MyChart, whether it was for a doctor message, a lab test result, whatever it was, they get an email. At the bottom of the email was information about Research Connections. And then finally is the actual research studies page. So obviously on that page, they can opt in or opt out of contact. And whenever they get a study opportunity sent to them and they go to their research studies page, there is a line at the bottom of the research study description that says they can, if they want to opt out, go up above and opt out. And that's shown a little bit better here. So on the research studies page, we had introductory information about what research is, how they could learn more, who they could contact if they have questions. And then there's a participant preferences section where they can say, yes, keep contacting me for research, or no, do not contact me. And they can actually select the types of research they're interested in. Also on that page would be any new study opportunities that have been sent to them. And they can say, I'm interested or I'm not interested. And any active studies that they're already enrolled in is also on this page, provided that the study has been set up in eRecord. When we launched this, and we tracked it for about 6 months before we started sending messages out. And essentially, most of our patients who went in here, of the ones who did go in here and make a choice, most of them said, keep contacting me. 15% said, do not contact me. So, so the process for MyChart for recruitment was set up with some rules, I call them. And this was, they wanted to make sure that as an institution, we're using this tool appropriately for the right research studies. So first, everybody has to get a CTSI consultation if you want to use this tool. And that is so that they can, we can make sure as at an institutional level that it's an appropriate tool for the study at hand. Only children up to age 11 and adults can use MyChart for recruitment, only studies that are enrolling those populations. You cannot enroll teenagers with MyChart for recruitment because once a person turns 12, they have access to their own MyChart information. And our institution does not allow researchers to advertise studies directly to teenagers. So that age group cannot be used. You can't send messages to that age group, but you can for all adults and children until they turn 11. And then the research team is responsible for sending the messages and for tracking what happens to the participants after they respond so that we can evaluate the project. And this is different than some research teams. I'm sorry, this is different than some institutions and how other institutions have implemented MyChart. Some of them have what's called an honest broker set up so that the CTSI office or CTSA office sends the messages on behalf of the researcher. We don't do that here. We give the research team the list of patients. We help them by loading everything into eRecord for them, and then they do their own messaging. So this is the convoluted pathway of MyChart for recruitment in order to actually get ready to go and send messages. Researchers submit an online request for support, and then we do our recruitment consultation with them. And, essentially, most studies are approved to use MyChart for recruitment. The studies that we don't necessarily, well, we haven't received any studies that we've rejected yet, but studies we would not approve would be studies that are of a sensitive nature, like interpersonal violence or weight studies, some cognitive studies. So it just depends on the topic of the study. So far, none of those types of studies have come to us yet, but I'm sure the time will come. So they meet with us. We say, yep, you can use MyChart for recruitment. They then get IRB approval, and that approval requires both the approval of a section in their protocol that describes how they're going to run this and a contact message. So what the patient's actually going to read in their research studies page when they read about the study. They send their IRB approval materials to us and at the same time submit a informatics request to our informatics service in the CTSI. And this is where they work with informatics to really narrow down and identify the appropriate patient population for getting these messages. This can take quite a bit of time. It's about a 4 to 5 week turnaround for that to happen. Once they get IRB approval, they can also work with our Office of Clinical Research to set up their study in ENCORE, which is our clinical trial management system. And the reason for that is the only way to push study data over to the EPIC system. So it's a technical thing. But it also allows them to track what happens to people after they message them so they can enter enrolled patients in ENCORE as well. So they get the study set up. It gets pushed over to eRecord, and then the MyChart team works with us to get everything set up in eRecord for the research coordinators to message. So we load in all the list of patients they're going to message and their contact message that's IRB approved. They can then begin messaging, and they are instructed to message as many people as they want. But we tell them you really need to get back. If somebody expresses interest, you really need to get a hold of them within a day or two, or you're going to lose them. So we tell them, start out slow and ramp up if you need to. The patient then responds to the message. The coordinator gets a message in their eRecord in basket that they have an interested patient, and they can follow up with them and enroll them per their protocol. We then collect enrollment data on what's going on. And then at the end of the recruitment period, when they've enrolled everyone, the coordinator has to go back into the system and retract all of the messages that they sent. So if they don't, the study opportunity will stay in the patient's MyChart forever. So we have to kind of help them remember to do that. So some results. So we have data collected from both the first year where the studies were open to for all study teams to use, as well as the pilot period. We have 59 requests come through during that time. We consulted on 51, and 8 study teams felt they were doing okay with recruitment and didn't need to add on another recruitment channel. The average time from consult to study activation was 231 days during that time. 19 studies as of January 2023 were actually messaging patients. They sent 8,240 messages to 8,168 patients. And some patients actually received as many as 3 messages, so a message for a different study. Study teams were allowed to message patients twice. So if they didn't hear back from them the first time, they could message them a second time, but no more than twice per study. This is a graph of time to activation for the protocols that we had collected as of that point in time. The black squares are the piloted studies that we did in the first 6 months, and then we had a bolus of studies come through after that. You can see there seems to be a trend of getting the time to activation lowered. So I think we're getting better at this process as we go along. We tend to get a bolus. We had a bolus of studies come in for consultations fairly quickly because we were doing a lot of promotion about this service to the institution. But now we kind of get everybody's kind of heard about it, and we're kind of getting a steady state influx of requests for service. We've had a wide range of departments participate in this effort. So it seems to be of interest to all disciplines and different types of studies. The response rate varies by study. Some studies had really great response rates, some didn't. Just depends on the study and the best fit for, I think, the population that was contacted. This shows the response rates broken down by demographics. So of all the patients that were contacted, we had an overall response rate of about 23%. Which is actually not bad, considering this is cold contact of patients, of which they probably have never heard about research or gotten a MyChart message about research before. We had a little bit more female representation than male representation in the patients that were messaged, with maybe a little bit better response rate from women than men. Age-wise, we didn't approve too many pediatric studies. So only 16 pediatric patients have been messaged, and none of them have responded, or at least the parents have not responded. And we had a little bit lower, maybe response rate in the younger adult group, but everyone ages 35 to 95 had a similar response rate. We see a lower response rate for Hispanic patients. We also don't message a lot of Hispanic patients, and that's primarily because we don't have a very high proportion of Hispanic patients in our overall patient population. And the same is true for race. We're predominantly white patients, so we don't message a lot of Black or African American patients, but the ones that we do message have a lower response rate of 14% versus 26% for white race. So we have some work to do on improving the response rate overall and the response rate of certain subpopulations of people. This is kind of our funnel, our recruitment funnel. We sent 8,240 messages to 8,168 patients. 1,878 responses came back. Of those that came back, 636 of them, about a third of them, were patients who were interested in learning more, and the other 2/3 were not interested. So that gives us an overall interested rate of 8%. So when we consult with study teams, we tell them if, expect a 5 to 10% affirmative response rate and plan accordingly. So if you message, if you need 100 people for your study, you're going to have to message, 8,000 patients, but, know that you're going to get, if you message 100, 8 people are going to respond. So make sure you have the time to follow up with them. And of those 636, 156 of them were screened and or enrolled. One of the other things we wanted to know is when patients did start getting messages, did they stop opting out of future contact? And only about 5% of patients do that. So most of the patients, when they do get a research study opportunity in their email or by text or however they get their MyChart notifications, they don't tend to opt out after that. So that's a positive sign. So we then just wanted to see, okay, of the 636 that were interested, 480 of them were still interested and hadn't moved through the recruitment funnel. But the rest of them did, from eligibility screening. Some of them weren't eligible. Some were still waiting for consent, with 67 people on study at the time, 5% on treatment. These are just different study statuses that you can enter in our clinical trial management system. And some people had gone all the way through to off study. The reason we think this number sits here at interested is for a couple of reasons. One is the teams need reminders to update the status in the clinical trial management system, but study teams have reported to us that they do have a hard time getting the patients to respond to them. So although the patient saw the message, said, oh, I'm interested, when the study team tried to follow up with them, a day or 2 days later, or even sometimes weeks later, they could not get a hold of the patient or get them to answer them by calling or email. These are some comments that we've received from our study teams about MyChart for Recruitment. In general, everyone is really glad that we've implemented this service. This person says it's very helpful to talk through MyChart for Recruitment, as well as recruitment materials, graphics, and suggestions for future growth of our research program. Using MyChart for enrollment made things so much easier and faster than having to go into clinics and wait to speak to potential participants. We used CTSI MyChart for Recruitment. It turned out helpful, but time consuming, and it does take time to go through the process, as we've seen. The CTSI's assistance with recruitment through MyChart has been a game changer, immensely helpful in our ever increasing technology heavy age. And my feedback would be to improve the tracking of subjects in the eRecord interface. We actually had quite a few researchers come back and say, it would be better if you could do this in eRecord or that in eRecord, which has been very helpful feedback. And we're going to take that back to our MyChart experts over on the clinical side and see what changes we might make and how everything's set up. So what are the lessons that we've learned? All types of studies can benefit from research. Study teams needed support in identifying populations in the EMR. This can sometimes be difficult to figure out. They don't always know what data is available in the EMR that's searchable, or necessarily how to create the queries to get the most accurate population to message. They also needed support writing their contact messages in plain language. So that little description that the patient reads about the study before they decide whether to participate or not is very important. And often they were using language from sometimes consents, even though they're not plain language, or sometimes, from their protocol. And so Cody and I have done this enough that we could help them edit their language. There was a lot of confusion when this was rolled out about what can we use MyChart for and what can't we use MyChart for when it comes to research. And our institution has a policy that you can use MyChart to send study opportunities for patients, but once a patient expresses interest, you have to then take that conversation out of my chart. They only want it used after, they don't want it used after that point. And this is mostly because, they look at how many patients actually read their MyChart messages, I guess, and patients don't utilize their MyChart information enough, and they didn't want to also flood them with research MyChart messages. They want them to focus on the clinical ones. One good thing is that it's created a great amount of visibility for our other recruitment tools. So when they come in for their MyChart for recruitment consultation, we also tell them, we have this website, you should have your study on the website, and you can also use the registry to send messages to, and we have research match and all these, and we tell them about the surveys. And so it's really kind of boosted the use of all of our recruitment tools. So this is the actual MyChart for Recruitment working group that I'd like to acknowledge everyone that participated, both from the CTSI as well as the other offices. And then this is my funding statement, and I am free for questions. So thank you.
Thank you, Dr. Dykes. Carrie, it was a wonderful presentation and a really great study. Could I ask a couple of questions? So do you use Encore across your CTSI ecosystem? And if so, what hints would you give to me to get leadership to drop $1 million on Encore a year?
So we do not currently have a policy where all research studies need to be an Encore. All billing risk studies need to be an Encore. And that is the main reason why we purchased Encore, was to manage the billing risk implications of research. And it's worked well for that. However, trying to get departments to utilize it for non-billing risk studies has been difficult. Once they do use it, they find it very valuable. But getting them over that hurdle of taking the time and effort to utilize it can be daunting for us to convince them to do that. We are, however, in the process of working with leadership to increase the required studies that need to be in there. In particular, interventional trials of all kinds, regardless of whether they have billing risk or not, for safety reasons. So if somebody's getting an intervention and the study doesn't have to be an Encore, it doesn't end up in e-record. And then clinicians don't necessarily know that this person is getting this drug or this vaccine or whatever the case may be. However, right now, our current CEO is exiting our institution, and we will be getting a new one. And so nobody wants to make a decision now. So our current CEO doesn't want to decide for the future CEO that this is what the rule is going to be. But we do, we really have a hard time knowing even how many studies we're doing. Well, let alone where they're all at and their statuses, and nor do we have, adequate enrollment data on how many of our patients are enrolling in studies. So it's definitely a great tool once it's implemented, but it is a lift. It is a lift to do.
So we're currently pushing it up.
Yeah, well, that's great. That's great.
So so currently in the Department of Medicine, although the ICTR goes across Maryland, our MyChart responsiveness is about 35%. I don't know whether you think that's good or bad. But going on, so your time to activation, what do you mean by, is that first patient in or just when you sign off all the documents?
That is from the time that they come in for the consult to the time that everything's been entered into MyChart and the coordinator can sit down and send a message.
Okay. So 88 days is great. 400 odd days is not so
great. Right.
So what are the challenges there?
So part of that is in the CTSI side, Cody Gardner is the person who primarily handles all these MyChart for recruitment projects. Our response is really not the issue. The issue is the time it takes to figure out how to find the population in eRecord. Sometimes that's 2 or 3 weeks back and forth with the informatics team before they really nail down a good query. And part of it is just the research team's ability to manage, one more recruitment channel on top of the ones they're already doing for all the studies that they're doing. And so we're trying to figure out, ways that we can alleviate that burden by either, maybe don't have them worry about writing the contact message. Let us write the contact message. We do it a lot for our online study listings and stuff. So, trying to figure out what can we do for you to make it easier so that you're not having to take the time to do all these different steps. We can't do anything about the IRB approval. The querying is that is simply resources. The more query builders you have, the faster that process will go, but that's just a resource issue with the institution. So we're just trying to help study teams not get bogged down in any of the steps that they have to do to figure that out. I think once everyone has done this a few times, that that those long activation times will start to disappear. I think a lot of this is just learning the process and how to get through it. And for some study teams, they never used Encore before. So or even eRecord. We have research teams that aren't clinicians, right? So they don't have access to eRecord already. So they have eRecord training to do, they have Encore training to do. And so it's a kind of a learning delays because of learning. And I think once they've done it a few times, that'll get easier for them.
Does your hospital have to approve all protocols as well?
No. It's up to Cody and I and the IRB as to whether they can use my chart or not.
Well, I'll stop there, and there are other questions in the chat.
Yes, I see some in the chat here. Okay, there's an AI taking notes. Oh, can you add the JHU link to the chat? Yes, I can do that. Let me get out of let me stop sharing first. Where am I? Here I am. Stop sharing. Okay, I will put that in the chat as we talk. And then they want the consortium displayed. Oh yes, I can. I don't have the code, but I can probably find the link. I can put that in there while we talk. Okay. Inpatient or outpatients are included. Both. So I'm trying to think, have we had any inpatient studies come through? I don't even know if we've had any come through yet, but there's no restriction if they're enrolling inpatients or outpatients. I think for the most part, inpatients are may not necessarily be looking at their MyChart while they're in the hospital, although when my husband or my brother was in, he was getting pinged about stuff all the time. So they may, but both would be eligible to do. And I think that's the only question I see so far. Let me find the link to the webinar from Hopkins.
And Dr. Dykes, I don't know if you can see, but there's also, in addition to the chat, there's a question and answer, a Q&A.
Oh, yes.
There's one question there as well.
Yeah, that's a great question. This is from Stephanie Ashley, who actually is the manager of a very large population-based study. So Stephanie's question is, what is the overall rate of patients who have active MyChart accounts?
So in our institution, we are at somewhere around 65% of our patients have active accounts. Yeah. I'm not entirely sure how they define active, but they've all signed up. Whether they've used it within the past year, or some other parameter, I'm not sure, but that's how many patient records have MyChart activated.
Thank you.
Yeah, and that, that's another thing. One of the other kind of lessons that I think is important to think about is, we rolled this out without any communication to our patient population. In fact, we do a very poor job, unfortunately, of communicating research to our patients in general. So when people walk into our institution, we want it to look like we do research here, and there's really no real effort to educate our patients about that. And so I think one of the reasons why we got a 23% response rate and not higher than that is because our patients don't really think about research when they come here. And so I think one of the things that would make a MyChart for recruitment effort a lot more successful is if in companionship to that, you had a research marketing effort that not only pushed that research is done here, but that the MyChart portal could be a way for patients to learn about research. I think it would actually help MyChart registrations and get more MyChart use. And so, we keep talking about how we might best do that in the future. We have not come up with a plan yet. We are in the process of writing our renewal for our UM1 and have proposed some sort of marketing plan, which will have to get developed, but have put funds in for that. So I do think that as an institution, it'll work better if there's patient education to go along with it.
Right. Carrie, do you know how many MyChart accounts there are at Rochester?
I don't know the number. We have about 2 million records. So 65% of that.
Yeah, that's a lot. So so we have a joint MPI CTSA with our buddies across town, and we just went through that. And thankfully we didn't annoy the reviewers too badly. But yeah, that's fun. So good luck in that. And
yes, thank you.
And they have multiple hundreds of thousands. They're not in the millions yet.
Yeah, one of the rules of the process, and I talked about how some institutions implement this as an honest broker. Yeah. We didn't do that because we give our research teams direct access to patient information. But what we did do is sometimes the inclusion exclusion criteria were general enough that they would get 50,000 eligible patients, and instead of giving them all of them, we said let's start with a limit of 2,000. So we kind of put a cap on it and said we're only going to give you 2,000 patients at a time. You can get more if you need more, but we're going to start with 2,000. And so we instructed them, of the patients that you could message, who do you want to start with? Do you want to start with men? Do you want to start with women? Do you want to start with older people? Do you want to start with people who have this particular lab result, right? You can narrow it down. Do you want to focus on, Black or Latino patients? And so with that many records, research teams could get tens of thousands of eligible patients, and then you have to figure out how are you going to navigate that. We found that very few teams came back and asked for more patients out of the first 2,000. That was usually more than enough for them to handle and deal with. So I think it worked well putting that limit on there. You know what? I have to scan the QR code in my presentation to get the link so I can then put it in the thing. I don't know how I'm going to do this. Not on Zoom, because I can email. Man, technology is great until you try to actually do stuff. Okay, there's that. Copy that and put it here. I email it to myself, and then paste. Do that. All right, I'll have to figure that out. I was going to send these slides to you. Is that okay?
Yeah, that would be great. Thank you.
Okay. And then you can just share them with everyone who attended, and all the links and codes will be there for everyone.
Okay. Maybe one last question. Do you have any pearls for retention?
Pearls for retention. Communication with the research subject. We've learned that in the research subject survey that we did, a lot of the feedback we get is, one, they want to learn about the results of the study, and they tend not to want to participate again because they never found out what happened with the previous study they were in, right? So making sure you share results with people. The other thing is, be continuous communication with them. Some studies are very long, recognizing birthdays or other milestones in their lives, giving them the opportunity to just, be personable with them and chit chat. And, especially older adults, they love to talk to you. And, so we train our research coordinators to spend time, talking to them about their lives and, what's going on, and not just get right to the point. Birthday cards, things like that work great. Postcards regularly work great. It's really about building the relationship with the subject over time. And a lot of the comments that we get from the research subject survey are, oh my gosh, Dr. Such and Such is wonderful. The research team was great. Everyone was so friendly. It's all of that kind of feedback. So we know that works, and they appreciate that.
Yeah, that's pearls indeed. Absolutely.
Yeah.
Thank you.
Yeah.
Well, Sam, did you want to thank everyone and close?
So Dr. Dykes, this was really, really wonderful. Thank you so much for coming.
Sure.
For those who are still on the Zoom, please just take a minute to scan the QR code and fill out the survey if you haven't already. Just a reminder for everyone that next week's Grand Rounds is going to be in person in the Shock Trauma Auditorium for the Pinkoffs lecture. So really look forward to seeing you all there. Thanks, Dr. Dykes.
Thank you, everyone, for coming.
Thanks, Sam. Thanks, Carrie. Bye.
Bye.